Hey there, Gators. This is the lecture review for therapy and treatment. We have our student learning outcomes. So for this unit, we're going to talk about perspectives on psychological disorders, we're going to talk about treatment options, biomedical as well as psychological treatments, and then talk about some issues with providing treatment. So what comes to mind when you think about therapy for psychological issues? So if you're like most people, when you think about therapy, what you're going to think about is something like laying back on a couch and having a therapist behind you while you spout poetic about everything that's ever happened to you ever since you were, an infant. So that's what most of us think when we think of therapy, but that's far from the only option. So there's tons of different ways to get therapeutic help from someone, from a clinician. So we're going to talk about some of those ways, talk about some of the theories behind some of these ways. But first, we really need to start with the past. So the treatment of mental illness has a really, really rough start. So it's not something that is pleasant to think about, especially as a psychologist. It's really heart-wrenching to think about what we did for individuals with mental illness in the past. But the important thing is that we thought it was helping. So most of the time, these things were not done in order to harm. Many of these things were done because it was thought to be the best help of the day. So for much of history, though, the mentally ill have been treated poorly. So we've thought that this was caused by anything but natural causes. We thought it was demons and witchcraft and that you made God angry, all kinds of different things. But most of the time, then, this led to exorcism to get the demons out, led to things like trephining, which you can see a picture of a trephined skull there. So it's holes that were bored into the skull to let the demons out. Or execution or imprisonment. So we've had people burned at the stake as witches, and then a big part of our history has been in asylums. So the asylums then were not pleasant places to be. It wasn't mental health centers like we have today. People in asylums were chained, beaten, subjected to all kinds of horrible treatments like insulin shock and wrapped in cold, wet sheets and made to lay in baths for hours and all kinds of treatments that now we would consider to be very inhumane and we would not use them. So it's not to say everyone believed these were appropriate treatments. We did have people like Pinnell arguing for more appropriate treatment. We also had, a woman named Dorothea Dix who was really advocating for better treatment. But unfortunately, this led to the creation of asylums in the United States, and these asylums were not great places. So many of these asylums were dirty, really didn't treat anyone for any of the illnesses they had, and just kept people for indefinitely, many times for decades. So there was no real treatment, no real hope of getting out of the asylum. So even though there's been people like Dix and Pinnell who really worked hard to kind of change our approach to mental illness, it took a long time for there to be real improvements. So around the 1950s and 60s, we first had antipsychotic meds introduced, and this was huge because then we have someone who's experiencing psychosis, like someone who's experiencing symptoms of schizophrenia, for example, can now take a medication and have those symptoms reduced, and so they have no need to stay in a hospital long term. They can take their medication and come out and live in the world and, experience a typical life. So this was a huge game changer. Around 1963, or in 1963, we had a law that were kind of, stop the institutionalization, especially for decades, of individuals with mental illness, and start trying to put mental illness care within the community. So the idea there was that those released from these mental institutions were going to get treatment then at these community healthcare centers. But really, when we had this mass institution or deinstitutionalization, where people were kind of removed from these institutions, the infrastructure in those community centers were not there. So instead of having this seamless transition between the institution setting and an outpatient treatment setting, instead these treatment centers were underfunded, understaffed, and unfortunately it led to many people with mental illnesses being homeless or in the criminal justice system, which is still a major issue that we have today, is many individuals who are homeless or who are in the criminal justice system have untreated mental illness. Today, though, we have a lot of care options. So we have different practitioners like psychologists, psychiatrists or medical doctors, social workers, many different types of therapists, but we still do have barriers to treatment. So we might not have insurance that covers the treatment that we need. It can be hard to get a culturally competent therapist, which we'll talk about. It can be hard to make your schedule work with that of a therapist. So there's still, major issues with therapy today, but we've moved quite a bit beyond our kind of barbaric roots there. Two types of therapy that we're going to talk about. We're going to start with psychotherapy. So this is more of the psychological approach, the psychological basis to therapy. So you'll see that you're already familiar with a lot of these terms because we've talked about them in psychology. The biomedical therapy are more medical or medical procedures or medications. So we'll talk a bit about that as well. So really, when I say, the therapy is based in psychology, that really means you know this stuff. So we've had a whole semester of psychology. So if you think about then these terms, so what would happen in therapy that was really based on the work of Freud? So you know about Freud, psychoanalysis, what would that look like? What would play therapy look like? So we've talked about play in the lifespan development chapter, how important that is for children's development. So what would that look like? Behaviorism, so therapy based on the principles of behaviorism. Cognitive or thought therapy, what would this look like? Humanism, we've talked about at great length, so that idea that humans are good and valuable people. Biomedical therapies, we've talked about the biological perspectives. Individual therapy, you know this as well, so it's one person. Group therapy is a group. And couples is, people in a romantic relationship. And then family is the family unit. So this is what we're going to talk about in the next few slides, but you already know this stuff. It's not brand new. So the psychoanalysis, we've talked about Freud, but psychoanalysis was really that first form of therapy. So this is something that people would do, and it would take years for them to participate in this therapy. So psychoanalysis was not something you could do, three or four sessions and feel better. It would be kind of reevaluating your whole life, and it would take years and years, sometimes decades. So Freud thought that the problems were a result of this trauma that you've got repressed and all these feelings from childhood. And so this therapy, I have a video linked here, you can kind of see what the therapy would look like. But he would ask people then, he'd sit behind him in this couch, that's Freud's actual couch in the picture, and then just say, start talking, tell me anything that's on your mind. If people would start talking and then they'd stop, he'd say that was resistance. So you were about to get to a breakthrough and then your mind kind of stopped you from saying it. He thought transference was important, so eventually in these years of being together in this therapeutic relationship, the client would transfer important emotions, maybe about their mother, their father. These important relationships would transfer those to the therapist and act accordingly. And then, of course, Freud was really big into analyzing dream content. The play therapy, this is used with kids, so it's this process of play. It's therapeutic play, though. We might, people might role play. Children play out their hopes and their fantasies, their traumas, their experiences. Some might say, like, play with these dolls and show me what a family does, what a family looks like, and be able to see maybe some of that trauma experience in the family and help, kind of work on those narratives for the kids. And it could be helped to make a diagnosis as well. Behavior therapy is really based on principles of behaviorism, which we've talked about, so we're applying those principles of learning. So the first things you should think of then are classical and operant conditioning. So that's what we're going to apply. So counter conditioning, this seems like a lot of text and kind of a big thing to understand, or difficult to understand, but it's really not. So you're all familiar with this. So if you've got, something that you've been conditioned to do, counter conditioning is just trying to teach you to kind of move away from that thing that you've already learned. So it's, in the case of aversive conditioning, you've got a response between maybe drinking alcohol and feeling good, but now we're going to try to add something like a medicine, anti-abuse, so that if you drink the alcohol, you immediately vomit and get very sick. So you're trying to make that new association between drinking alcohol and becoming incredibly sick. And then hopefully you'll learn that association and stop drinking the alcohol. We also see people use exposure therapy. So with this, clients would be exposed to something that they're afraid of, and it would be paired over time with more neutral things that are more exciting for them, and they would eventually kind of get used to that fear-provoking situation. So Mary Carver Jones was the mother there of behavioral therapy. What she did, she had a little kid who was afraid of rabbits, and so this kid was afraid of rabbits but loved kind of crackers and milk. It was his favorite snack. So what Mary Carver Jones did was eventually pair this little boy, gave him his crackers and milk, and had the bunny in the room. So he's enjoying this delicious snack while the bunny's kind of in the room a little bit further from him. But then eventually she would start bringing the bunny in closer and closer and closer while the child was enjoying their snack. So I'm sitting here eating my snack and the bunny's kind of, progressively each day getting a little closer to me. And so she eventually kind of paired then my delicious snack with the rabbit being in the room. So she kept doing this, pairing over and over. I get my favorite snack and there's a rabbit here. I get my favorite snack, here's a rabbit, and just paired those over and over until eventually the kid paired or, kind of associated that good feeling of your favorite snack with the rabbit. So it was not afraid anymore of this rabbit. So it was this counter conditioning. So it used to have one conditioned response, over time pairing a new conditioned response with that. Systematic desensitization is based on this idea of exposure. So what individuals will do, or what the therapist will do for this, is if you have something, especially like a phobia, something you're really, really afraid of, they'll eventually, or they'll kind of go through this whole thing where they construct an anxiety hierarchy with you. So there's one here for someone who has a phobia of going to the dentist. So you can see the degree of fear. The very, very most fearful thing is 100. Kind of something they're afraid of, but not as intense, is 10. So driving past the dentist's office on a Sunday afternoon gives them a little bit of anxiety, but not much. So that's where then the therapist would start. So they would have the client work on becoming relaxed, relaxing their body, getting used to this thought while they talk about driving past this dentist's office. While they actually do drive past the dentist's office, the client would try and relax themselves. As soon as the client was able to do that and relax themselves, they'd keep moving up the hierarchy. So eventually they would get to sitting in a dentist waiting room, and the client is working to control their body, calm down, pair that relaxation with that sitting in a dentist room. And then hopefully, going up this hierarchy, the patient will eventually be able to go to the thing they're most afraid of, which is having that dental drill in their mouth while the cavity is being repaired. So the idea is just to keep pairing that over and over until they're able to do this task. This can also be done with virtual reality, so I have a link in there that I think is really fascinating. Using operant conditioning, though, we can also really shape behavior. So this field of ABA, applied behavior analysis, this is something where they use mostly reinforcement, but also some punishment, not harsh punishment at all, but largely reinforcement to help kids learn new behaviors. This has been shown to be really efficacious with individuals with autism. And then a token economy, this is when you kind of give somebody a little token, a little tiger buck or a little star or something, and they keep working up to be able to get a privilege. So if you get 5 stars, then we go to a movie. If you get 10 tiger bucks, then you get to buy a little present out of the gift box. So, kind of reinforcing those good behaviors by giving small tokens. So we've got through our, psychoanalysis therapy. We've talked about a behavioral therapy. Cognitive therapy is kind of working on the thoughts. So this is, trying to understand how thoughts, the things we think, can lead to us feeling upset. And the therapist then will try to challenge some of those thoughts, change those dysfunctional thoughts, and talk about how we misinterpret situations. So if you fail a test, this is something that happens to all of us eventually. So if you fail a test, if you have an internal belief, I'm worthless and stupid, that's going to lead to depression. If instead you have an internal belief, I'm smart, didn't study for this test, I can do better, I'm capable of better, then it doesn't lead to depression. So that thought is an important process, and it can be something that we work on challenging our thoughts and changing our thoughts. So that's a big basis of cognitive therapy. Cognitive behavioral therapy is really interesting. So it's kind of combining the behaviorism and the cognition. So it's a really, really effective form of therapy. One of the first forms was this RET, rational emotive therapy, but really we're trying to change cognitive distortions, work on self-defeating behaviors. Some self-defeating behaviors we have are things like all or nothing, like if I can't get it done perfect, I shouldn't do it at all. Overgeneralization, so I messed up one test, I'm going to mess up all my tests. Jumping to conclusions, so someone looked at me funny, they hate me. So there's many ways in which we kind of distort our, our social information, and so it's trying to help us work through and be less distorting in our thoughts. So we'll see this graphic here. We've got that A is the activating event, so some kind of thing, maybe you fail a test. B is your beliefs about that, and that leads to C, the emotional consequences. So the beliefs are super important. We're able to then go to D and challenge those beliefs. So if my belief is I failed my test because I'm stupid, I feel terrible, but then I can go to dispute that. So what evidence do I have that I'm stupid? And most of the time then we can't find any evidence. I've gotten to college, I've worked really hard, I'm not dumb, I'm not a person who gives up, and so you don't have evidence. So you dispute that belief, and then you have new beliefs. I just need to study harder. I need to try harder. That's E. So the new beliefs replace those irrational ones. Humanistic therapy we're familiar with. So the humanists, they really think, we're good people inside, we have a lot of potential. So the idea for a humanistic therapist would be to help people achieve that potential and become self-aware, self-accepting. Carl Rogers is a huge name in this field. We've talked about Rogers before. For his therapy, it's the client-centered therapy. He doesn't give directions. So if you're like, I'm having a rough time with my mom, he's not going to be like, well, you need to go tell your mom X, Y, Z. He doesn't do that. It's non-directive. So instead what he does is kind of just listen, help kind of give unconditional positive regard. So I'm going to listen to you. I'm going to like you. I'm going to be really genuine with you. I'm going to show that I care about your emotions, and I'm going to show that I accept what you're going through. So that's more of the therapy there. They're not giving advice, not giving specific tasks that you need to do, but just listening and kind of viewing you as a real good person who's able to solve their own issues if you just have a good sounding board. So the link I've got in there is Eliza. So she's a kind of an artificial intelligence humanistic therapist. So you can go in there and talk to Eliza, and she kind of, does this process of, responding and trying to be accepting and show empathy. It's kind of funny to try because it is an AI, it's not a person, but it's kind of a fun experience to try. So this chart will just show those various psychotherapy techniques. You can kind of review them there. But when we evaluate them, so oftentimes after we learn about all these forms of therapy, people then say, well, what's the best? Which one should I go for? But really there's not one answer to that. So really successful therapy relies on several factors. It should be based in the evidence. It should be research supported. The person who's giving the therapy should have expertise. So we need somebody who's, trained. And then really it relies a lot on the patient. So do they want to be there? What are their culture? What's their preferences? So there's no real one answer for everybody. No approach is necessarily more effective than the other. So we don't have one therapy that works and then the rest of them are garbage. It's not like that. It's really about you and your values and preferences. So for me, I know I work really well on behavioral therapy. So if I can kind of shape my behavior by giving myself consequences, that's what works really well for me. And really rapport is important, so that kind of relationship between the client and the therapist. So it should be a good relationship, a strong one. They like each other. They're able to kind of work well together. Those are really important factors. So not one being better than the rest. And that'll bring us into biomedical therapy. So we're going to talk some about these. So with our biomedical therapies, we have several approaches. So the most common one that most of us are familiar with and have heard of are psychotropic meds. So these medications, a whole bunch of different types of meds, but they're really trying to treat the symptoms of psych disorders. There's also other forms of biomedical therapy, so more like procedural forms. So ECT is one we still use. So a lot of people have a negative view of ECT. They think it's something barbaric. It's really not. So it's really medicalized. It's they do it in a safe manner, and they only do it as a treatment of last resort, often for very severe depression. So if you have someone who says, I'm very, very depressed, if I leave this situation, there's a good chance I may commit suicide, it is really important to intervene there. So something like ECT may help knock them out of that suicidal ideation and help save their life. So it's a treatment of last resort, but it's not as barbaric as we often see it portrayed. And then things like TMS, so we have new treatments that are coming out that are still kind of more experimental, but TMS uses magnetic fields to help improve depressive symptoms. So all of these are kind of relying on a medical approach. This chart gives a lot of the commonly prescribed psychotropic meds, so you can kind of read through there and see what it's used to treat, some typical brand names you might hear of, what they do to work. So you'll see a lot of that, early material that we've talked about with the brain and bio. You'll see that, kind of come back up here in this chart. And then some side effects. So a lot of these medications do have side effects. So we really have to weigh, the extent of which the symptoms of the mental illness are causing us distress and try to choose the medication with the least amount of side effects that will work for that individual. So you can see the types. We've got the antipsychotics, which we've talked about, developed early on in the 50s. And, this really made a huge difference for the number of people institutionalized. We've got some atypical antipsychotics, which have fewer of these horrible side effects, like tardive dyskinesia. So the antipsychotics really helped with the mental illness symptoms, but they led to a lot of physical issues. So things that look more common to Parkinson's. We saw a lot of facial twitching, muscle movement. And so the atypical antipsychotics really help to reduce this. Antidepressants are things that help to stabilize mood disorders. Anti-anxiety helps to reduce anxiety. Mood stabilizers are for individuals who, have that bipolar symptomology, so some mania as well as some depression. They help stabilize the mood and kind of get it back in that more average range. And then stimulants are things that we use for individuals with ADHD. So you can kind of read through that and see these mechanisms of action. We also mentioned briefly in the slide for this, that there's different treatment modalities, and these make sense. They're exactly what they sound like. So for the individual, it's the client and the client and the clinician working together. The amount of time they spend working, it depends really on the needs of the client. So it could be something only a couple sessions, could be several years of sessions. Group therapy, we've got individuals who have similar problems, so maybe some anger issues or depression, and they meet with a clinician in a group with other clients. So So we might have one clinician and 6 clients, and they're kind of meeting. This can really help to decrease shame. So it's like, look at all these other individuals also struggling with the same issue that I struggle with. It can lead to support, healthy confronting. So, you said you weren't going to do this behavior. Here you are doing it. What are we going to do about it? So kind of a healthy form of confronting. But there's other issues too. So people can be shy. They can be worried about their personality clashing. So it's not for everyone to meet in a group. Couples therapy, this is typically the 2 individuals who are in this intimate relationship. They're trying to solve some problems that they'd have, so both of them would go together. And then the family therapy is using this idea that the family is a system. So we can't just take one person out of there and say, this person is the one with the issue right here. Instead, it's saying, how can the whole family work together to support these individuals within the family in a healthy manner? So it's using the entire family, to help to really support whatever problem they're having. Substance abuse and addictive disorders, this is something that, we kind of know is very, very important. It's a really common issue. Addiction is a chronic disease. Unfortunately, addiction rates have been rising, and so this is something really, really important. So it's chronic. The goal is to stop that drug-seeking behavior. Treatment is super cost-effective when compared to just putting people in jail or to not treating the addiction at all. So treatment is a great thing. But then how do we treat individuals with substance use disorders? There's certain characteristics that we know are important. So it should last for a while. It doesn't really work just to get somebody out for a weekend. You need more time away from that situation. It should be holistic, so not just focus on, getting over the symptoms of the drug use, but instead, the mental state, psychological, spiritual, if someone's interested in that aspect, physical, it should be holistic. Oftentimes incorporating a group is important, so it normalizes and shows that people can overcome these issues, and typically medications are involved as well. The big issue with our substance-related disorders is that many times people have comorbid disorders, or they're comorbid in their disorder, so they have a substance use as well as a bipolar diagnosis, or a manic or a depression diagnosis, or an anxiety diagnosis. So many times people will use substances as a way to kind of cope with psychological illnesses. So this is something that's really common. So many times then treating that underlying psychological illness will also help reduce the substance abuse disorder. Our final topic here is the sociocultural model. So this is something that's really important for anyone who wants to give therapy to realize. So individuals from ethnic minority groups use mental health services less frequently than do Caucasians. There's a lot of reasons for that. So this gives some opportunity or some ideas of what's happening there. So it can be availability issue, not having insurance, transportation there, lack of bilingual treatment. So if you don't have someone who speaks your primary language, it can be really hard then to express yourself fully. Stigma, shame, all kinds of things. So really what we need for our individuals who are going to provide any form of therapy at all is to become culturally competent. And so this really involves a process of understanding issues of race, ethnicity, of culture, of socioeconomic status, of all of these things that are really tied in to one's culture. So it's very, very important then, if you ever want to be a clinician or anybody who gives any form of therapy, to become and work towards being culturally competent. So just the last thing we've got is just a couple of vignettes to think about how this looks. So we've got here, you can read this, but generally, we've got a baby from a Muslim family. They're from Afghanistan. This clinician made the appointment for 4 p.m. after the school day is over. They, found the family spoke English. She tried to say, there's a neurological impairment, and she wanted to be seen by a doctor. But then the mother said, she wants her husband to be there to call the agency and arrange. The father never called, and the mother never returned. So this is an opportunity then that was lost to help this individual, this baby. Another vignette. So she evaluated a Pakistani child with severe reflux. However, when they were looking at the child, did not seem to have any issues with drinking the liquid in the bottle, but she did have issues with solid food that was incredibly spicy. So then the clinician just said, can you give her some different food that's not so spicy? And so then the mother was unhappy with that. And then finally, this clinician went to an Orthodox Jewish home, brought out toy farm animals, had a dinosaur, and the family was appalled that she brought a piglet, and believed, that was questioning whether or not the therapist actually believed in dinosaurs. So she brought a pig, she brought dinosaurs, she brought these animals that the parents didn't want to see. So she wanted somebody else to come evaluate her child. So what the clinician has said here in these situations, there's a lot of ways she could have been more culturally competent. So with the Afghan family, she made the appointment based on her own schedule. She didn't ask if the whole family was going to be there. If the father had been there, she might have been able to make him feel more comfortable, and he might have followed up those calls. With the Pakistani child, she should have made clear that the food was perfectly acceptable, but that the child maybe not be able to take it at that time. So instead, we're not maybe insulting the food choice or being negative about that food, but instead just saying maybe this isn't the right one at this time. What else could we try? Some other options. So it's all about, kind of being respectful of that food. And then finally, with the Hasidic Jewish family, realizing that even if you think your materials are perfectly fine, they may not be. For other cultures, to think about, am I bringing a pig? Am I bringing a dinosaur? Am I bringing things that are going to seem strange to this family? And if possible, to bring other objects, just to know about that culture, know about, important animals in their culture and things like that. So trying to understand, if you're going to go out in the field and work with people, to understand their culture and their differences. But that will finish us up for therapies and for treatments. So have a great day, Gators. Thank you.